It's my pleasure now. We're going to kick off our main session tonight, and our first speaker, who can't be here in person, but nonetheless has provided a very inspired and inspiring talk to start us off, is Dr. Jane Philpott. Dr. Jane Philpott is the Dean of the Faculty of Health Sciences here at Queen's, and she's a medical doctor, former member of Parliament. Prior to politics, Jane was a family doctor for 30 years and spent the first decade of her career in Niger, West Africa. She was the chief of family medicine at Markham Stouffville Hospital and associate professor in the Faculty of Medicine at the University of Toronto. From 2015 to 2019, she served as the Federal Minister of Health, Minister of Indigenous Services, and President of the Treasury Board and Minister of Digital Government. Jane, as I said, regretted not being able to be here tonight, but very graciously recorded, as I said, an outstanding talk, which we're going to share now to kick off our first session tonight. And we'll start with Jane's talk, and I'll see you back after that.
Hello, it's my pleasure to be here with you today at the Canadian Global Oncology Workshop. My name is Jane Philpott, and I have the pleasure of being the Dean of the Faculty of Health Sciences at Queen's University. I wanted to also acknowledge where I'm reaching you from. I'm situated here in the beautiful city of Kingston on the shores of Lake Ontario. This is the traditional territory to Haudenosaunee and Anishinaabe peoples, and it's my pleasure to be able to join you today and to acknowledge those who have cared for this land over millennia and continue to live on the land today, the land the rest of us now enjoy as a place to live, work, and play. I wanted to also tell you a little bit about my background in terms of the perspective that I bring to this topic that you've asked me to address today. I'm a family doctor. I spent the first decade of my career living and working and practicing general medicine in rural Niger in West Africa. I also spent a significant amount of time working in Ethiopia in training in family medicine, and then spent a number of years in my career working in politics, where I had the great privilege of being the Federal Minister of Health, as well as the Federal Minister of Indigenous Services. So hopefully you'll find that my comments will be able to bring in that breadth of experience, because you've asked me some very interesting questions to look at today. And I wanted to actually go over them now because they are so helpful in terms of framing the conversations that you're going to be having throughout the workshop. One of the questions was, what is the nexus between improving health equity and improving health equity in low and middle income countries? And more specifically, what can individuals like yourselves, as well as your teams working to improve health equity in Canada, learn from people and teams who work to improve health equity in low and middle income countries? I know that you're also planning to explore the opportunities for collaboration between individuals and teams working to improve health equity in Canada, and how those lessons can also be adapted to those who are working to improve health equity in low and middle income countries. One of the questions that often comes up is, should there be a dichotomy, or if so, what is the difference between working in Canada and working in low and middle income countries on these similar types of goals? And is there a moral obligation to address inequities in Canada first? Some have also asked the question as to whether or not the failure to address inequities in Canada impacts the legitimacy of our work in global or international settings. So what I wanted to do today was give you a talk based on some of the principles that I think should be considered in trying to answer these questions appropriately, based on my experiences over the last 4 decades of working in similar types of settings. And there are many themes, of course, that can easily be conflated, terminologies that I think are often interchanged but mean slightly different people. So I wanted to start with that. You all are familiar, of course, with the challenges between the difference of global health versus international health, challenges about thinking about the difference between global health and health inequity. When we talk about health equity, others will say that the real term should be substantive equality, for example. And of course, what are the links of all of these to population health? that also raises the question as to what the distinctions should be between the field of global health or health equity and very much related fields around Indigenous health, decolonization, and reconciliation. I won't go through the differences in terminology and definitions of all of those terms today, but I wanted to acknowledge that there are a number of different considerations, and yet the principles are very much the same. So what have I learned about this kind of work that I think can be applied to pretty much all of the fields that I addressed above? And I have a series of 10 principles or lessons, life lessons that I wanted to share from you. And I think the first one is to understand what it is that drives us. Imperative for this work. And I think that the imperative for me, whether I'm talking about inequities in Canada or inequities internationally, is the reality that the world is a very unfair place. And this is something that it doesn't take very long to discover when you're working in settings where there are great health inequities. But of course, when we talk about the fact that the world is an unfair place, we have to simultaneously acknowledge that all of us have received an enormous amount of unearned merit and opportunities. We've gotten the good side of the deal when it looks at when you look at the matter of equity and inequity, and there are a number of responsibilities that are incumbent upon us as a result. And so that leads me to my second lesson learned, and that is that I think it's really important for all of us, before we get involved in this kind of work, or as we continue to do work in international health or similar fields, to acknowledge our unearned privileges and the implications thereof. When you look at the matter of unearned privilege, I think about Dr. Stephanie Nixon from the University of Toronto, who wrote a fabulous article in December of 2019 that appeared in the BMC Public Health Journal. And she talks about the obliviousness of people in positions of privilege is a key strategy that's required to sustain the hegemony of systems of inequality. And so we can't be oblivious to our positions of privilege and the situations in which we find ourselves if we're trying to do this work. Of course, some people immediately become defensive when you start talking about acknowledging privilege. That's not the right response. The correct response to recognizing privilege is not denial or guilt. It's actually self-reflection, and it's informed. Number three, I always like to remind people about thinking of what the roots of inequities are. This is something that became very, very clear to me, if it wasn't already clear, when I worked in the field of Indigenous health, and specifically when I worked in the federal government. You know, back when I went to medical school almost 40 years ago, we talked about a very biomedical model of medicine, about sickness and health. And then over the years, over the decades, we began to talk a lot more about the social determinants of health being the root causes of what makes somebody sick or what makes somebody well. But in fact, there are deeper layers that need to be considered. And those are the layers of human rights, Indigenous rights, inherent rights, for example. And it's incredibly important when we think about the health outcome gaps that are experienced by Indigenous peoples versus non-Indigenous Canadians to recognize that those health outcome gaps are rooted in the denial of rights, the denial of human rights, for example, but also the inherent rights and treaty rights that are laid down for Indigenous peoples. The fourth area that I would like to point to as a core lesson or principle for those of us who are doing work in international health or global health, and that is the risk that is involved. And what do I mean by that? I mean, what is the damage that we could potentially do in this work if we haven't, for example, examined our motives? I began to learn about this as I read a book that some of you may have read. It's called Orientalism by Edward Said, and it's a fascinating piece of work that looks at the drivers to explore exotic places and how people can escape from their otherwise dull and mundane existence and historically choose to explore the far off or the Orient in the case of this particular book. And I think those of us who are involved in global health need to be cognizant of that risk that also exists in terms of what is our motivation for being involved in this kind of work. One of the other authors that I often like to point to when I'm thinking about what motives there are in our work is the author Chinua Achebe, who may be known to many of you for his most famous work, Things Fall Apart. But many years later, and just before his death, he wrote another book in which he talks about the role of the foreign correspondent. And he acknowledges that foreign reporters have a role in telling important stories and bringing media attention to global crises. And it's not perhaps dissimilar to the work that doctors who work around the world need to be thinking about. But as he writes about the foreign correspondent, he cautions about, quote, the moral danger of indulging in sensationalism and dehumanizing the sufferer, end quote. And that, when I read that piece from Chinua Achebe, I was very struck by the moral dangers that are upon those of us in medicine as well, to indulge in sensationalism as we describe this kind of work and thereby dehumanize those with whom we work. I think there are very similar hazards in the fields of global health, or in the fields of addressing the inequities in health that exist here in Canada. The risks may not be entirely avoidable, that's the reality, but it's worthwhile to be aware of the danger. And what Achebe goes on to point out in that commentary is that when we are comfortable and inattentive, we run the risk of committing grave injustices absent-mindedly. And so this is my reminder to myself and to all of us to realize that we do run risks of committing grave injustices in the spirit of trying to actually address health inequities, and it's something that needs to be understood. Number 5, I wanted to think about a little bit about the cost-benefit analysis of this kind of work, and think about who has something to gain and who might potentially be paying the price. There's a cost for our international partners to work with us. Those of you who are working internationally will know this. When newcomers arrive from international sites, all of the normal activities often stop, and the newcomers are oriented to the place of work. They require extra attention. It takes people away from doing their ordinary work. And when our learners work in international settings, that also adds burdens of teaching sometimes. And there's, of course, a burden for the participation of research. This is a huge topic and not something that I want to try to oversimplify today, but I think it's a consideration that is equally relevant whether we're considering international work or work with marginalized populations here in Canada. We have to actually think about who is doing the work to improve health equity. We, in many cases, are doing the research and publishing the papers, but where is the cost of the work involved, and are the cost benefits fairly shared? The 6th thing I wanted to talk about is the role of being an ally. And I think here is where we start to begin to understand how we can potentially be most helpful. Allyship, as I alluded to earlier, involves this very important work of authentically reflecting and self-examining, understanding our position of privilege. And Stephanie Nixon, who I talked about earlier, writes in that same paper on the coin model of privilege about the fact that allyship is not an identity, it is an ongoing practice. It's not who we are, but it's what we do. Probably the best definition of allyship comes from Anne Bishop, who wrote that an ally is someone who recognizes the unearned privilege they have received from society's patterns of injustice and takes responsibility for changing those patterns. So that comes from Anne Bishop of Nova Scotia, who wrote a fantastic book called Becoming an Ally: Breaking the Cycle of Oppression in People. And some of my final points, number 7, whether we're doing this kind of work in international settings or whether you're working with communities here in Canada, we have to be good listeners. We have to ask communities what they need. It's very easy to make mistakes by assuming what communities need by understanding a perspective on wellness and health and the goals of the communities that we're working with, which may be radically different from our own, and where our own worldview clouds the understanding of what a community needs. So I think just a reminder to all of you, which is probably something you've all been doing all along, but the enormous need to study and read not just biomedicine, but to learn history, to learn cultural protocols of the communities that we work with, to visit communities and not simply spend brief periods of time, but ideally to live in much as one can. When we worked in Niger, we spent a considerable amount of time learning the language so that after our first year or two there, I was able to do all of my clinical work in the language of Hausa, which is the local language of the community where we worked. It's not always possible, but even learning a few phrases and starting to try to understand some of the nuance of language can be remarkably helpful. And learning the distinctions of the different people groups that you might be working with, no matter what other communities we go to work in, as you get to know the dominant cultures that are a part of that context, to spend time understanding the distinctions of the cultures that may make up a particular community. Number 8, after we've listened, I wanted to point out our obligation to act on what we hear or act on what we learn. And acting often involves things as simple as speaking up. Speaking up, of course, is the minimum that we need to do. Working to change those patterns of injustice is the ultimate goal. But and understanding and filling our own documents with knowledge is insufficient in the field of working on addressing inequities. My number 9 lesson is just to recognize that you will make mistakes. Cultural humility is key in this work, to realize that there are many things that we don't know, and to acknowledge what we don't know, to apologize when necessary, and to ask for help. And finally, number 10, make friends. This is an incredible opportunity to work across cultures, to work across countries around the world or in other communities in Canada. And no matter who you work with, I hope that you are making friends along the way with the partners that you're working with. And if that's one of your primary goals, you won't go wrong. So I wish you well in the rest of your workshop. Thank you for the privilege of sharing a few ideas, and I hope it will help to set your discussions in a good context. I wish you the very best. Merci beaucoup. Chimigwech.
Scott, you're on mute.
So I think you'll agree that was a very inspiring and inspired talk, both to launch tonight's session and to launch the workshop. And I'll pass on my thanks to Jane. I know she wished she could be here tonight, and I'll pass on my thanks for that excellent talk. I'm going to pass on now to my colleague, Dr. Craig Earle. Dr. Earle's Chief Executive Officer at the Canadian Partnership Against Cancer, a medical oncologist at Sunnybrook's Odette Cancer Center, where we work together for more than a decade, a senior scientist at ISIS, and a professor of medicine at the University of Toronto. Thanks, Craig, and I'll hand off to you now.
Thank you, Scott. It gives me great pleasure to introduce our panel for tonight. So in order, Dr. Angeline Letendre is Treasurer and Research Chair at the Canadian Indigenous Nurses Association and a lead research scientist at the Alberta Cancer Prevention and Legacy Fund of Alberta Health Services. In addition to leading many projects in Canada, Dr. Letendre also partners with researchers in Australia, New Zealand, and the United States on cancer-related research with Indigenous populations in those countries. Dr. Avram Denburg is a staff oncologist and clinician scientist at the Hospital for Sick Children. His research centers on issues related to pharmaceutical policy and drug access for children in Canada and internationally. He's past chair of the Essential Medicines Committee for the International Society of Pediatric Oncology, a member of CADIT's Board of Directors and the Ontario Steering Committee for Cancer Drugs, and he chairs the P&T Committee for Sick Kids. Dr. Aisha Lofters is a scientist at Women's College Research Institute, where she holds the chair in implementation science. She's an adjunct scientist at ICES and an associate professor in the Department of Family and Community Medicine at the University of Toronto. Aisha is also the provincial primary care lead for cancer screening at Cancer Care Ontario, Ontario Health. Her research program focuses on improving quality of care in cancer screening and prevention, particularly for populations that experience marginalization. Dr. Letendre.
Okay, what am I supposed to do? Hello. I think I did what I'm supposed to do. So thank you very much. I'm very honored to present here amongst these prestigious scientists and people working in health across Canada. Thank you very much. So I'm presenting to you here for where I live and where I hail from in Treaty 6 territory in Alberta, also home to Métis Zone 4. Alberta, if you don't know, is the only province as well with Métis settlements and land-based agreements. My father's family side are Cree and Cree Métis from a traditional Métis community of Lac St. Anne. And my mother's side is Scottish and English from northern communities in Alberta. I do have a presentation that I believe that they are bringing up for me. I don't see it. So is the presentation up?
Just one moment.
Thank you. I'm going to try really hard to keep to my 10-minute timeline. So I'm going to speak to you today on equity in Indigenous people's health in Canada. For those who aren't aware, there are 3 distinct groups of Indigenous people recognized in the Canadian Constitution of 1982, which are First Nations, Inuit, and Métis people. Next slide, please. So I wanted to share with you some of the important events in Canada that have shaped Indigenous people's health, because I think to work in areas of equity, it's really important to understand the transformation that's taken place in terms of Indigenous people and their health and the Canadian healthcare system. So our last residential school actually closed in Canada in 1996, which is really only 25 years ago. And I'm sure most of you are aware of the residential school legacy and a lot of trauma and harm that has ensued from that. Then there was the United Nations Declaration on the Rights of Indigenous Peoples. Canada is a signatory on that document, and in particular, I just wanted to refer to Article 24, which has 2 main clauses, and they speak to the Indigenous people and their right to traditional medicines and to maintain their health practices, well as the right, this includes the right to access without any discrimination to all social and health services. And the second clause has to do with the equal right to the enjoyment of the highest attainable standard of physical and mental health. And states shall take the necessary steps with a view to achieving progressively the full realization of this and the other rights. I think it's important to note that these are minimum standards for the survival, dignity, and well-being of Indigenous peoples worldwide. These rights are to be interpreted, understood, and protected and exercised on in a distinctions in Indigenous group way. That is to say, it is up to the specific Indigenous peoples, groups, or nations, even communities, to decide how that would be exercised. And then in 2015, most of you have probably heard of or even read the Truth and Reconciliation report that came out of the residential school legacy, and the calls to action, specifically 18 through 24, do have to do with health. And then in 2019, there was a national inquiry into the missing and murdered Indigenous women and girls in Canada, as well as our LGBTQ. I'm sorry, I don't know the whole acronym. They keep adding to it. And there was a report that came out of that. I think it's important to know that, for Indigenous women even, they are 2.5 times more likely to visit emergency departments just for even gynecological reasons. And so when we start to talk about some of the concepts that have emerged and arisen out of this conversation on equity, such as cultural safety, some of these facts and understanding where Indigenous people fit within that picture are very important. There's also a call to action within this Indigenous missing and murdered women and girls, and specifically 7.2 calls upon governments and health service providers to ensure that health and wellness services for Indigenous people provide supports for healing from all sorts of unresolved trauma. So I asked the question here, when we think about concepts such as cultural safety, how those are defined and what that means, is that really enough for us to consider? And the last event that I placed on the timeline for you is about Joyce's principle. And the death of Joyce Echaquan, who's from a First Nations in Quebec, if you don't know, was actually filmed live or sent on YouTube by Joyce herself as she lay dying and was not treated at all acceptably within a healthcare facility. And so there's a principle that came out of a brief that has been given to the government of Canada and Quebec for adoption, and it aims to guarantee all Indigenous people have the right to equitable access without any discrimination to all social and health services, as well as the right to enjoy the best possible physical, mental, emotional, and spiritual health. And it requires the recognition and respect of Indigenous people's traditional and living knowledge of all aspects of health. And so in response to that, the Government of Canada has provided $2 million to the Attikitimek Council and First Nations to work on advocacy for Joyce's principle. Next slide, please. So there you have call number 18 from the Truth and Reconciliation Commission of 2015, which is calling on governments to acknowledge the current state of Aboriginal health in Canada. And I think largely within Western literature and dialogue, most of us have seen the picture of the fence, where you have what looks like a boy who's either looking over the top of the fence, is below the fence, or he's actually looking through a crack of the fence. Next slide, please. And so here is the Missing and Murdered Women, Indigenous Women and Girls final report, and a call to action from that, asking governments to ensure that the rights and the health and wellness of Indigenous people, and specifically Indigenous women, girls, and that long acronym of people, are recognized and protected on an equitable basis. Next slide, please. Next slide.
Sorry, just one moment.
Thank you. So from Western perspectives, a lot of the language that we're talking about in research and science right now is around a concept of intersectionality, which promotes an understanding of human beings as shaped by their interaction and different social locations. Métis researcher Peter Hutchison talks about cultural safety as being a response to the colonization or the colonialism that you're experiencing within your region. And so dependent on where you are, where you're accessing services, that would have a significance. So these interactions occur within a context of the connected systems that we have within our country and those structures and powers that be. And through such processes, there are systemic bases of privilege and oppression, and many of which Jane talked about. Next slide, please. I think this is really my last slide. What I wanted to talk about for the last couple of minutes was equity through an Indigenous lens and talk about land, language, and community. First of all, I want to acknowledge the work and the good energy of many Indigenous peoples and researchers who are working to better understand and transform health systems in our country from within the context of equity. So this really is some of the work that I've done, and it speaks to my perspective and what I have learned. And so I have done my due diligence as a scientist with our team. We've looked at the literature out there on equity and health equity with Indigenous people. And this is why I provided you with a timeline for that broad view of the transformation by Indigenous people to be self-directed and self-directing in their own health and their own health care. This is absolutely essential and critical to the experience of equity and getting to a place of what demonstrates equity in health services and other kinds of programming services, systems that we have within our society. I think it's speaking with a lot of elders and knowledge keepers about this. I know it's speaking with Leah Bill. We talked about this overemphasis on equity to the point of exclusivity. But really, what demonstrates equity for Indigenous people? Is it that fence and where you sit to look through that? I mean, that doesn't look at questions like how is the quality of life defined? And I can remember an elder, and I'll never forget one of my teachers saying that when the spirit is strong, life is good. So when we begin to work with elders and knowledge holders, as me and my team have been doing, and in collaboration with other Indigenous peoples and communities, elders and Indigenous peoples look to the earth as the archetype for all of this work. And as well, the principle of there's no culture without language and no language without culture. A good example of that are the medicinal properties and how the Indigenous words and languages used to name them will often have those properties of that medicine right within that name and that language. And the last concept that I'll share with you is the thinking around community as an organism. I once was privileged to hear part of a creation story from an elder and knowledge holder who is passed. And this was about 15 years ago. And I left that room thinking, boy, have we got it wrong. The way that we set up our health systems and the way that people access care. Communities are not stagnant, as you know. They're always growing, progressing, and adapting to change. And our thinking on equity, how we look at that, and the ways in which we transform our health system to meet and demonstrate equity for all peoples needs to be adapting and changing. And for Indigenous people, this really involves concepts of place, space, and purpose, which is absolutely always grounded in connectedness and in our interrelationships with each other, the earth, inanimate objects, animals, and even the spiritual world. Thank you so much. It's been an honor to spend this very short amount of time with you on such an important topic.
Wonderful. And I think we're now going to hear from Dr. Avram Denburg. Thank you very much, Dr. Letendre.
Hi, everyone. Can you hear and see me?
Yes, we can.
So for some reason, I'm getting a grayed out button for sharing my screen.
I can pull up your slides. Just one moment. I can do that.
Thanks so much, Laura. So it's a total honor and a pleasure to be here. It's very humbling to go after Dr. Letendre, but I wanted to thank the conference organizers, including Drs. Rodin, Barry, Earl, Hamad, and others for including me, and to Drs. Philpott and Letendre for so movingly starting us down this river that we're on together. Lori, let me know. Okay, great. So we've been asked to consider some huge and complex and really vital questions together today, and it's hard to tackle those in 10 to 12 minutes. So I've taken as my job really just to surface the questions and try to sketch their boundaries rather than provide any specific answers. Next slide, please. So first, some acknowledgements just of my situation in terms of place, position, and perspective. I'm very grateful to live and work on land that's the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and which remains home to many diverse First Nations, Inuit, and Métis peoples. I obviously come at this as a white male settler physician and researcher at an academic institution in a rich country, who's been reared on a largely Western worldview. So my pursuit then is humility about the limitations in that perspective, gratitude for the diversity of perspectives around me, and solidarity with those whose voices and perspectives have been silenced or sidelined. Next slide, please. So the motivating questions we've been asked to consider today are: what is global health and what constitutes a global health issue? Whether our moral obligations to address health inequities in Canada supersede those related to health inequities internationally, and to consider whether the presence or persistence of health inequities in Canada obviates the possibility or indeed the legitimacy of global health work abroad. Next slide, please. So to ensure we're talking towards the same thing, I wanted to begin with a definition of global health. Copeland had already in the Lancet in 2009 defined global health as an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. They state that global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level clinical care. So this is a pretty comprehensive definition of global health. But I would argue, next slide, please, that it's missing some really vital things at its core. Next, click. And those are any substantive mention of dynamics of power, of social and political systems, and of systems of ideology that really structure and abet health inequities globally and within Canada. Next slide, please. And so what I want to challenge us to do today is to take a critical lens and turn that on global health, just as Dr. Letendre and Philpott have done. I understand global health, drawing on some work by Andrew Pinto and Ross Upshur, as a contested term that's used mostly by academics like myself, practitioners and donors in high-income countries, that describes activities, as Jane noted, that were previously labeled tropical medicine or international health, that has some laudable stated goals, which include reducing health inequities and improving the health of everyone with strong roots in public health and human rights, and that has interventions that span a wide range of activities and disciplines. I want to point out, though, that those interventions are very typically influenced by the social, political, and economic philosophies of those who fund and direct them. And importantly for our discussion today, following on Dr. Letendre, that obviously discussions of global health are relevant to discussions of health work with marginalized communities in high-income countries. Next slide, please. I think ethics has a lot to contribute to the conversation around global health, and I wanted to invoke the role of global health ethics in clarifying the ambit of global health, the duties inherent in global health work, and the legitimate means of discharging those duties. So I understand global health ethics as inquiry into the ethical dimensions of the political, economic, and social structures that condition disparities in health outcomes within and across societies, and importantly, that emphasizes a critical approach that's alive to issues of power. I see this as dovetailing quite closely with the political economy of health, which Anne Emanuel Byrne nicely defined as considering the political, social, cultural, and economic contexts in which disease and illness arise, and examining the ways in which societal structures interact with the particular conditions or factors that lead to good or ill health. Next slide, please. So this brings us to one of the key questions at consideration today, which really at its base is, what is our duty to others? Another way of putting this might be, what constitutes a moral community and what are its boundaries? Next slide, please. And so to get at this, I wanted to tell a couple quick stories as metaphors for moral communities. The first, the picture on the left invokes Peter Singer's story about the pond that he first told in a 1975 article and then recapitulated in his book, The Life You Can Save. And there he tells us a very personal story, and it's a story about you, about each of us. And you're walking to work and you pass a pond that you normally do on your way to work. You're late for work, you're dressed in your finery, and you notice splashing in the pond. And rather than the typical playing of children, you quickly notice that there's a child who's struggling to stay afloat and is drowning. And you recognize that unless you go in and save this boy, he will drown. But you simultaneously, intuitively recognize that if you do that, your shoes will get wet and ruined, your clothes will get wet and ruined, and you'll be very late for work. And Dr. Singer invokes this story to challenge us with the triviality of the everyday, of the quotidian, how it interferes in our thinking, but more specifically, to pose the question to us critically of whether the value of a life saved is contingent on the proximity or immediacy of suffering. And he posits that in the same way we have a duty to save this child, as most of us would submit to, we have an equal and equally compelling duty to save the girl in Yemen who is dying from cholera. A comparable story, although told much earlier, by Charlotte Perkins Gilman from 1895, is the story of the unnatural mother, about a mother who is walking in the valley above her community when she sees that a dam has given way. She begins to rush down to the community and recognizing that everyone in the community is going to die unless it's evacuated. And on the way, she passes her house where her infant child is sleeping. She rushes right past the house, recognizing that if she doesn't get to the community in time, everyone will die. And noting that if she leaves her child behind, the child may die. She tells the community that the dam has broken, and she tries to rush back to her house to save her child, but drowns in the act. And she is branded by members of this story, other characters in the story, as an unnatural mother. And what Gilman is provoking us to ask there are whether there are times when our obligation to others is equal to or greater than that to our own family, and whether our obligations to our own children override our obligations to strangers, no matter how great their suffering or need. So this is really a limit case story to challenge the boundaries of moral communities. Both of these stories challenge us to interrogate or reconceive deeply held notions about the relationship between proximity and duty, attachment and care. Both invoke comparative lenses about potential lives saved, near and far, whether in emotional or geographic terms, to problematize the relative value we intuitively or habitually place on these lives. The stories urge us to begin to develop a more global state of mind about who matters and what we should do about it. Next slide, please. The field of bioethics and its progressive enlargement of its lens from interpersonal ethics to public health ethics, and now most recently to global health ethics, has traveled a similar trajectory with contributions from a range of disciplines and philosophical perspectives that we don't have time to go into. And I borrowed this slide from a mentor of mine, Sali Benatar. Importantly, human rights and public health ethics, which we've talked about already today, have figured prominently in this transformation towards a global state of mind. But I want to argue that we need to take a further step. We now need to expand to and detail a global or planetary health ethics that's premised on greater recognition of our mutual interdependence, importantly, relationality, and the need for solidarity. Next slide, please. I think global health ethics has a lot to say about this. So the other key question that arises when considering these stories and these questions today is whether there's a hierarchy of duties to others and what determines relative priority on that hierarchy. And a common approach to this is really to think about a pyramid of enfolded or layered duties to others, premised on things like geography, society, community, and towards its peak, affinity for others based on close relationships or familial relationships. And many of us would sort of intuitively say, as the Gilman story does, that relationships towards the top of this to family and others arguably have are higher in the hierarchy of duty. The stories we just heard seek to subvert this pyramid, but in truth, they tell us little about the nature of our duties to others beyond that they exist. They seek to break down false boundaries, but not to build clear roots linking us across these divides. So I think we need to move, next click please, from this hierarchical conception of duties to a more relational understanding of our responsibilities to others. And I think this is in part what Dr. Letendre was getting at. One in which, next click please, all of these domains figure in a web of interactions and interrelationships across place and time. A conception of relational justice, in the words of Thomas Pogge. Next slide, please. So another way of putting this to us, and I borrow this from Lauren Tynan, who's a Trowulwey scholar from Macquarie University in Australia, would be how comparative and relational approaches might answer this same question. How are a river and a mountain similar? The comparative approach would say they're both part of nature. And this is in part what Singer and Gilman have tried to do with these stories. They're telling us that I am part of the same world and part of the same species and part of the same enfolded being as the boy in the pond and the girl in Yemen with cholera, and therefore I have duties to them. Next click, please. The relational perspective, however, takes a different tack, and it would argue that the river and the mountain are similar because the river flows down from the mountain. In other words, the river and the mountain are contingent on one another and in a contingent relationship. Next click, please. Lauren Tynan writes that a relational reality creates relationships between ideas or entities, and is an effective force that compels us to see the world, to feel the world as kin. And to feel the world as kin is to enact a relational ethos, where importantly responsibilities and accountabilities issue from that. Next slide, please. And I think this is hugely important for conceptions of global health, that we need to really move away from competitive hierarchies and towards relational responsibilities. Competitive hierarchies of duties tend to create degrees of otherness between different populations of people. They tend to reify different groups, and they create false dichotomies between global health projects and global health work that create impossible priorities in that they stymie action, obscure the potential for mutual reinforcement of different global health projects, and distract, importantly, from a focus on the essential how of global health work. Next click, please. Relational responsibilities, by contrast, insofar as they recognize that global health inequities are a product of systems of oppression, and that we are implicated in those systems of oppression and benefit from them, invoke humility and understanding our place in creating those disparities in health, provoke reflexivity in how we might overcome those systems of oppression, induce solidarity amongst peoples across different contexts, and create possible futures for global health work that seeks to ameliorate those disparities. Next slide, please. So in terms of a move towards practicing relationality and invoking Albert Schweitzer in saying that the first step in the evolution of ethics is an enlargement of the sense of solidarity with other human beings, I wanted to put forward a couple of premises for our discussion and our panel today. And the first is that we owe equally and urgently to those of us in need, regardless of geography, as a result of the institutional systems of political and economic oppression that we've engendered and from which we continue to benefit. And the second is that particular commitments, be they local in Canada or abroad, can legitimately grow from different experiences and attachments, and that their legitimacy rests in precisely how we nurture them and carry them out. Next slide, please. So I submit these thoughts as a plea for building a community of good relationships in global oncology, at home and abroad, that can continue to ask critical questions about inequities in cancer care and outcomes, and engage in answering them in a spirit of humility, reflexivity, and solidarity. And so I think that the purpose of this session in this larger conference, in fact, is, and I'm so grateful to the conference organizers for bringing us together accordingly. I'll end there and really look forward to Dr. Lofters' presentation and the discussion.
Wonderful. Thank you so much, Dr. Denburg. And Dr. Lofters, we will turn it over to you.
Hi, everyone. Can you hear me?
Yes, we can.
Okay. And I'm having the same issue where I can't share my slides.
Just give me 1 second.
Thank you so much, Laura. All right, just bear with me 1 second. Can everyone see them?
Great.
Okay, great. All right, so thank you, everybody. Thank you to the organizers for having me. I feel very honored and humbled to be on this panel and to be with you all here this evening. Just very quickly to introduce myself, because this was already done, but just to give perspective on how I come to this topic. I'm a family physician actually here in Toronto, Canada. I'm a health services researcher. So I really focus on the primary care aspects of cancer, so cancer screening and prevention. Much of my work has been in the area of cervical screening, very much with a health equity lens, coming from the experience of being myself a Black immigrant woman. With the work that I do, I'm really seeking to understand which structurally marginalized groups experience inequalities in Canada, how are those inequalities experienced, and what can we do to develop interventions to address these inequalities. So, one of the questions that we were asked to consider was, what is the nexus between improving health equity in Canada and improving health equity in low middle income countries? And as I said, a lot of the work that I've done has been in the area of cervical screening. So this brought to mind for me the recent WHO global strategy to accelerate the elimination of cervical cancer, which is a global strategy with global implications. So this is a quote from the Director General of WHO, who said that through cost-effective, evidence-based interventions, including HPV vaccination of girls, screening and treatment of precancerous lesions, and improving access to diagnosis and treatment of invasive cancers, we can eliminate cervical cancer as a public health problem and make it a disease of the past. So obviously a very noble and aspiring goal to actually be able to eliminate a cancer through acts of prevention, really, so through vaccination and screening, and of course through treatment of precancerous lesions. And these are just the global targets that exist. So the idea of 90% of girls around the world being fully vaccinated by age 15, that 70% of women are screened with a high performance test by 35 years of age, and again at 45, and that 90% of women identified with cervical disease receive treatment. So the 90, 70, 90 targets, as they call it, by 2030. Now, we know, though, that these goals are not going to be as easily achievable for every country around the world. So this map is really showing us the age-standardized cervical cancer incidence in 2018, so just a few short years ago. And we can see that the darker shading is countries where the incidence rates are higher, and lighter shading is countries where incidence rates are lower. And it's pretty clear that as a country's GDP goes down, the incidence rate goes up. So cervical cancer really is one of those that is a quite clear marker indicator of global inequities. But those inequities are not just from one country to another country, they also exist within countries. So even though in Canada itself, Canada as a whole, cervical cancer rates are quite low and cervical cancer screening rates are quite high, we do see vast differences if you dive deeper and look deeper within the country, within the nation. So this is just a graph from some work that I did a few years ago. So when we looked at Canadian-born women under the age of 50 who were living in the highest income neighborhoods and who were in a primary care enrollment model, which essentially means that they were formally registered with a family physician in a type of model where there are financial incentives for cancer screening, that of those women, almost 80% of them are up to date on cervical screening. But when we looked again within Canada, these people could be next to them in the waiting room, that when we're looking at women who had immigrated from South Asian countries, who were over the age of 50, but still eligible for screening, living in the lowest income neighborhoods and not formally enrolled in one of these models, it was less than 22% were up to date on cervical screening. So we see this very vast difference even within our own wealthy nation. We also have universal healthcare, so healthcare for people who have OHIP in Ontario and health insurance in other provinces is fully covered. So there is no cost, no direct cost for cervical screening, but we consistently see these gradients when it comes to income and cervical screening. So this graph, as you can see, although it's old from 2009 to 2011, the data haven't changed, the gradient hasn't changed, and in fact, screening rates have gone down. And we see that going from the lowest income neighborhoods to the highest, there's a steady increase in screening as income goes up. And remembering that it's not about a direct cost of screening, but obviously there's something else underlying these gaps that we see. And we not just see this in cancer care. I had to mention COVID-19. We are still very much in the midst of this pandemic. And this graph just illustrates that within Montreal and Toronto, when we're looking at neighborhoods, that as the percentage of Black people in a neighborhood increased, the COVID-19 mortality rates increased as well. And this is not about biology or genetics. This is about structural racism and structural marginalization, well within our own Canadian borders. So health inequities exist between nations. We know this. We see vast differences between countries when it comes to health outcomes. And we also have to recognize that health inequities exist within nations as well, within all nations. So this means attention is needed both locally and internationally. We don't have to, and I feel shouldn't be choosing one over the other or one versus the other and creating that dichotomy. And we just recently, these last few days, have heard about this new variant of COVID-19, Omicron, and many people are recognizing that this really brings vaccine inequity home to roost, because many high-income countries have had an abundance of vaccines and many other countries have had very, very low vaccination rates. So now this gives opportunity for variants to emerge, which affects all of us. So again, it just shows that we can't create this dichotomy and treat it as one versus the other. No, we are still a global community. So this makes me think about mutual learning. So again, in the work that I do around cervical screening and prevention, an example that comes to my mind is HPV self-sampling, which is a method of cervical screening where a person can do the test themselves, essentially. And this has been used in countries such as Uganda, it's been used in Guatemala, been used in a variety of what we call global settings, but has also been used here in Canada. It's been used among women in living in rural areas, among Indigenous women, women living in inner cities. So it's this one intervention that we use in a wide variety of settings, but all trying to address structural barriers that people face when it comes to cervical screening. So this is just one example, but I think it shows that when it comes to the work of health equity, both globally and within a nation, there are some key points that I wanted to emphasize that I think were mentioned in the previous presentations. One is recognizing the importance of the community voice and community expertise. There is an expertise that comes from living and being embedded in a community and being part of a community that many researchers don't bring, and we have to recognize and prioritize that. Related to that is the idea of building trust and meaningful partnerships. We can't parachute into communities, do a research project, and then leave. This is unethical, it's harmful, and it's damaging to communities and to researchers going who want to do meaningful work after that. So we have to recognize that this type of work takes time to build trust, to get to know people, for people to get to know us, and to develop meaningful partnerships with mutual learning going in both directions. We also have to understand the role of systemic marginalization. So very often we focus on individual choices, individual behaviors, but we have to recognize the systemic roles that lies behind that. What have people experienced over the course of hundreds of years? You know, there are people who've experienced genocide, slavery, racism, classism that has been going on, and that leads to many of the barriers that we see. So we've got to focus on that and recognize the role of that and not just be thinking about individual behavior. And then the biggest thing I would say for this work, both locally and internationally, and this was touched upon already, as well as the idea of humility. So recognizing that we may be experts in methods or content, but we have to recognize others' expertise and recognize that we're going to make mistakes and that we don't know it all. So this is probably the biggest takeaway that I would say is approaching any and all of this work with humility. So I do know that we are right at 7, so I think that was my last slide, so I will stop there. And thank you so much again for the opportunity to speak.
Great. Well, thank you so much, speakers. I think we have all learned a lot from the presentations this evening, and I think there's been a lot of new perspectives that have been raised. I'd like to just remind everyone here that This is an opportunity to ask our panelists questions, and you may post questions in the Q&A or in the chat, and we'll be trying to moderate both. I have a question perhaps to get us started, and I think a number of you in the presentations talked about the need, and Dr. Lofters, you spoke about this just in your last comments around the need to build trust and meaningful partnerships, and how we can't parachute into communities. And Dr. Philpott talked about the concept of cultural humility. And I wondered if you could all speak about how you've seen this affected work in global cancer control, and really how far do you think we still have to go to achieve or improve cultural humility?
So I guess I can start. I'd love to hear perspective from the others. I think a lesson that I have learned on the job, I guess you could say, you start out thinking, oh, we're going to hold a community advisory committee meeting, and then we're just going to tell them what we want to do, and we're going to go off and running. And you realize through experience that no, it doesn't work that way. People need to, as I said, need to know who you are and what you're about and what it is that you want to do. And you need to be willing to realize that the ideas that you have are wrong, that they don't apply, that they need to be changed, that you need to take 10 steps back. And what I've learned through the hard way is that it's about, that's where that humility piece comes in, right? And going to the community and seeing what are the questions that they want answered and what's the work that they want done. It's not just about us, thinking about our CVs and getting excited about ideas in our head. Obviously that's important, and we can bring those ideas to the community, but we want the work that we do to be meaningful. So I think in the time that I've been around, I think I am seeing change in that regard, but there's still a very long way to go. I think funding cycles probably need to be changed to reflect that too. We get these short-term grants where there's a rush to get it in, and get somebody to write me a letter of support, and it's a 1 or 2 or 3 year grant, and it doesn't take into account the realities of the time it takes to build relationships and to incorporate ideas, and of course to also have research that's sustainable, so that you're not just jumping into a community doing some great pilot work and then the funding is over.
I don't have much to add to that. Aisha said it beautifully. The only thing I think I'd hit on that Dr. Lofters said right at the end is really just the importance of trust building, right? And longer term partnerships, so that you have the time and capacity to listen and to hear what priorities are within a given context and community, and create relationships where, as Aisha said, people know who you're about, what they're about, and you're creating community while undertaking research. That's really hard in the context of funding cycles, as Aisha pointed out, and I think that's a real challenge structurally for us, and in terms of promotional metrics at many of our institutions for those of us who are academics or physicians or what have you. So there needs to be some kind of cultural and political shift there, and I don't know how to undertake that, but I think if as a community we're working together to try to induce that cultural shift, we'll begin down that road favorably.
So I do agree. However, I think it's very unfair to place the onus for cultural safety, what that looks like, how that's measured, how that's demonstrated, how that's implemented, without talking about the system itself. When we talk about cultural safety, what are the indicators and the measures for that? We need to delve much deeper. And when we think about space, place, purpose, those concepts, it's even about what is the space. What's culturally safe? Do you understand? Do we know what's culturally safe about the space where patients are accessing services? I can tell you it's not in a line when you walk in the door of a tertiary facility and show them your cancer number. That's not it. That's a systems issue, right? There's a myriad of them. And it's not to say the system's really bad. It's about working better to understand what that means. And from the perspective of individual care providers, how do they fit within? How do they enact? How do they help to transform and understand what is important to look at as indicators of that for the system, and to actually transform it in a way where there's systemic change and an addressing of those barriers and putting those facilitators in place that enable care providers to provide that kind of service, and then enable Indigenous patients and other patients to actually access that kind of service and care. Thank you.
Thank you. I think those are really important comments to end this question on around, and I think that was raised by a number of you around these systems of oppression and how that can perpetuate a number of inequalities. There's a question in the chat from Melinda Mashonga. She asks, are there any strategies in place to address the inequities identified for the gap in cervical cancer screening in the immigrant population? And have these been evaluated around success or challenges?
So, I mean, some interventions, some strategies that have been used to address cervical screening inequities. So I think HPV self-sampling is a concrete one, but even how that is implemented requires a lot of thought. So is it a matter of, is it mailed to somebody? Is it a matter of it being done in a primary care provider's office? A lot of the interventions, I will say, I think that are successful, I think what they come down to, again, is that idea of community. So it might mean that there's a community health worker involved who is educating about screening. What does screening mean? What does a cervix mean? What does this concept mean? And embedding it not just in a conversation about cervical screening, but conversations about health, prevention, and wellness in general. And then often it's somebody from the community. And who is the community? I think it depends, but there have been many different contexts in which this idea of a community worker has been actually quite successful in increasing both knowledge about cervical screening and uptake of it. Because again, it's that idea of a trusted source who understands what messages matter and who understands what speaks to people, right, about the importance of screening. I think, and these types of strategies have been successful in a variety of contexts. I think the challenge often is, how are these sustained? And as I said, like, you'll see many pilot projects, you'll see projects that have happened in Canada in various provinces. I have done projects where we have community workers, community champions, but then how do you continue to fund those without getting that support from your institutional or jurisdictional health authorities?
That's great. And there is another question that's come in from the chat around whether there's a role for innovation in improving health equity, and yet, if yes, how to make it more broadly available and economically viable. Is it through education, through culture change, through new models of funding? We've talked about some of the issues around funding this evening. If any of our panelists would like to start with that question.
So I can start. Absolutely, yes. I think the answer is yes to that question. I think this is a really good question, and it's important. I think we begin by acknowledging the knowledge that exists in this area, and the experience and expertise, stories and experience of communities, patients and their families. You know, I'm always reminding myself and my team the knowledge upon which we base healthcare and prevention in particular. This is not new knowledge. These are natural laws. This is old knowledge. Eat well, get exercise, reduce your stress level. So it's looking to communities and societies and their traditional ways of sharing and transferring on that knowledge and providing the support for them to be able to transfer that. Mobilizing communities, I've been talking about this a fair bit lately, takes tremendous skill, passion, commitment, and love on the part of communities. And as funders and researchers and care providers and health systems, we need to really recognize that, and we need to absolutely fund it much better when a community is able to mobilize their entire community towards change in this way, whether they're Indigenous or immigrant or remote communities. It's quite phenomenal. And we also need to be looking at much better ways to measure that. We need to be looking to these funders to be able to transform their thinking in what is an important indicator for this, right? At a community level, not just individual. Thank you.
Thank you. I think the issue around transforming the way we evaluate projects and partnerships and how that impacts individual promotions or is viewed as academic productivity is certainly an important issue for many of the people and many of the participants in this panel. There's a question. We have time for one more question from Nazik Ahmad regarding the cultural norms of academic systems. How can they be transformed to align with humility and effectiveness of shared work in global health?
It's a great question from Dr. Ahmad. I think one thing that comes to mind often in academic systems, we focus on, let's call it the quantitative. So how many publications did you have this year? How many grants did you get? How much money did you bring in? How many presentations did you do? How many media interviews? And then that's how you are evaluated. So it's really about the numbers. And I think we need to make a shift to the stories. And by stories, I mean the stories of the impact. So you can have tons of publications and tons of grants and tons of presentations and not have done work that has had a meaningful impact. And obviously you can do very meaningful work, and many do who have lots of the quantitative aspect. But I think an opportunity to recognize the qualitative aspect of the narratives, the stories, and to have the chance to talk about the meaningful work that you've done. Because I've definitely seen, especially with folks who are junior, recognizing that the time it takes means that they're not pushing out publications the same as their colleagues are who might be doing let's call it community-based work. Mm-hmm. So I think that's certainly one thing that comes to my mind.
I was going to say much the same thing. I think the only thing I'd add to that, Danielle, really quickly is not just stories, but relationships. And I think this relates to the question around innovation that Angeline spoke to. I mean, every project requires innovation insofar as you need to build relationships anew, and you need to understand a context anew, right? And tell and create a new story together, right? So I think that's where stories and relationships are going to be so vital for changing culture. And that's the innovation that's needed in the context of our systems, I think, promotional, academic, otherwise.
Yep, and I think that is Laura coming on to tell me we're at time, but I think that is a really important way to end and really an important way to start our discussion and conversations tomorrow around how we can incorporate stories and relationships into our thinking around the impact of our work in global cancer control. So I'd like to thank all of our panelists for really the wonderful presentations this evening. I think this sets a really great tone for our discussion tomorrow. I'm going to turn it over to Laura to give some instructions on the next part of the evening for networking, and hope to be able to connect with the participants here over the next 45 minutes.